I am Shadi Reyes from Detroit Medical Center, and this is SIF2021 Conversation. With me is Dr. Neil Gheewala. He is a co-director of structural heart at Tucson Medical Center. Welcome, Neil.
Thank you.
Neil, just now we finished a live case broadcasted from Dr. Isaac Lab talking about mitral valve, and it was a phenomenal case.
Yes.
Given your specialty and interest, tell us about what we have now for mitral disease and what is future technologies.
Yeah, so that's a great question. So I think the mitral space, if the aortic valve was the thing of the 2010s, 2020s is going to be about the mitral and tricuspid space. Right. And currently there are two FDA approved technologies. One is transcatheter edge-to-edge repair with MitraClip, and valve-in-valve TM transcatheter mitral valve replacement with the Edwards S3 valve. Those are the only two FDA-approved devices. So there's a lot of room, a lot of space for other future technologies to come. The big thing about the mitral valve, it's a little bit different in terms of geometry as relative to the aortic valve. Right. There's a lot of things that we know about the mitral valves and things that we don't know about, and things we don't know to ask about the mitral valve as far as figuring out what the optimal therapy for this is.
To understand what we're looking at.
Exactly. And what will produce a near surgical-like result for individual patients based upon their pathology.
Exactly.
Things that we have to look at is mindful of who the patient is, how active they are, what their comorbidities have they been recently hospitalized for heart failure,
right.
How quickly they need a therapy, and then finally, how amenable are they to conventional therapy? For native mitral valve disease with mitral regurgitation, transcatheter edge-to-edge repair is FDA approved for high and prohibitive risk patients. Right. Although there are several trials undergoing right now, the Repair MR trial looking at the intermediate risk cohort, which is randomized to surgery versus MitraClip in a 1-to-1 fashion.
Nice. And this is for functional or degenerative?
This is the Repair MR trial is looking at degenerative mitral regurgitation. Okay. Currently for, and again, for degenerative, high and prohibitive risk is approved. For functional mitral regurgitation, that is defined by the guidelines as an EF of less than 50%. After optimal medical therapy, it is a class 2 indication for transcatheter edge-to-edge repair.
So what to determine, now we have a lot of patients that are sick, heart failure, being in the hospital for many days, diuresis. What to determine the patient is candidate for the MitraClip right now? Like, what are the things that you look for to say, you know what, this is time for you to get the clip?
In context of COVID or in context in general?
Let's talk COVID in general and how this changed during COVID.
Yeah, so in general, I think number one is optimal medical therapy. I think to make sure that, number one, we adjudicate the MR, make sure that there isn't a secondary etiology, as far as this ischemic MR, is there some need for revascularization? So I think doing a thorough workup is first. So doing your cardiac catheterization and transesophageal echo. I think that'll help to define the coronary anatomy, looking to see if this is a blood supply issue, and then TE looking at the anatomy, and then again classifying, is this a functional case or a degenerative case? I think that's the first thing to do. If this is a functional case, you should be on at least 30 days of medical therapy, and optimal medical therapy, similar to what they designed in COAPT, to ensure that these patients are optimally treated before they go to MitraClip.
And they get checked off by the heart failure specialist?
Absolutely, and that is a heart team evaluation.
And it's a purely valve issue that's causing the patient to come back to the hospital.
Exactly. Yeah. Now, if those patients come back to the hospital and have recurrent heart failure, in those cases, I've had to go ahead and just clip those patients to give them some element of relief.
And do you think, sorry to interrupt you, but do you think now you are becoming more proactive on jumping on these cases, giving the COVID to prevent patients coming back to the hospital?
Yeah, that's a great question. So I think that part of it is, I think that in the era of COVID, I think we've been having to deal with the capacity of our hospitals, how much volume they can do. Now, in our center, most MitraClips go home within 24 hours. We have recently started a same-day discharge program for these patients. In the era of COVID, that does help patients get treated faster. Yeah. What we know is that patients with valvular heart disease who get influenza have a much higher morbidity and mortality rate. And for COVID, that has been implicit and also been documented in a recent study as well.
Well, I mean, that's really, good to have you, Neil, today, and this is very good conversation talking about the mitral technology, what we have, how to select these patients, and how to manage them during COVID time.
Absolutely.
Neil, thank you so much for your time.
Thank you.
Please watch this video and others on SIF YouTube channel. This is Shadi Reyes from SIF 2021.